Okay, maybe we should get started. So I want to introduce myself, Matcheri Keshavan, and I think Rachel Hegde, who is our coordinator, will probably be calling in very shortly, and she will say a little bit about the sponsor of this program. Maybe we'll wait for her for just a second, then we can get started. Rachel, are you there? Yeah, so she'll probably momentarily be calling in, but let me say a little bit about this morning's activity. This is a monthly psychopharmacology consultation activity that is sponsored by the New England Mental Health Technical Transfer Center, MHTTC.
Oh, what do you mean?
Hello, everyone. If you are just joining in, you have microphone abilities. So if you're not speaking at the moment, please mute your microphones. And then if you do have a question, you can always unmute yourself. Sounds good?
Okay. So again, just to back up on what I was saying, this is an educational activity of the Mental Health Technical Transfer Center, also called MHTTC New England, which is supported by SAMHSA. So the goal of this activity is for us to review questions relating to psychopharmacology, at this time focusing on psychotic disorders this year, and then we will cover other disorders as we go forward, bipolar disorders and child psychiatry and geriatric psychopharmacology and so forth. My name is Matcheri Keshavan. You see this, I think the slide should be up introducing who I am. I'm a psychiatrist and a professor at Harvard Medical School. I also direct the Division of Public Psychiatry at the Beth Israel Deaconess Medical Center and the Massachusetts Mental Health Center in Boston. I have been in practice of psychiatry for over 30 years, and my particular interest is in psychotic disorders, especially in young people, adolescents and young adults. And so this is the second time that we are doing this educational activity. And I'm very, appreciative of the enthusiastic response by the participants, and in fact have received many questions, probably too many to be able to cover in this 1-hour session. So I will get started with some of those questions, and we'll leave enough time towards the end for people to ask any other questions that are on their minds that they want to bring up to the group. So we would like this to be as interactive an activity as possible. Vanessa, are people able to speak up and ask their questions, or would they have to type it into the text line here? I guess either would be, yeah.
Yeah, I believe they're able to speak up if they wish. We can give it a try, see if we can hear
They have to unmute themselves and ask the question, and then I'll be able to answer. So since the majority of the questions are in the area of psychosis, I want to start with one question that was posed to me as a kind of a good beginning level question that will address a number of issues in the management of psychotic disorders. The question is, what is the first line to treat psychosis in a 16-year-old? First episode with auditory and visual hallucinations, no substances, engaged in therapy. And second part of that question is, if voices are not occurring every day, would you still treat this? Very good question. As you all know, psychotic disorders like schizophrenia typically begin in adolescence. So onset in a 16-year-old is not unusual. So when a person is in a first psychotic episode, and we have made the diagnosis of a psychotic disorder, and the mainstay in pharmacological treatment for someone like that is an antipsychotic. Now, there are many options that are available, and if you're all able to see the slide, let me try to advance to the one particular slide that would illustrate that point. And there are several types of antipsychotic drugs. There is the first generation antipsychotics, and then the second generation antipsychotics, and the what you might call third generation antipsychotic drugs. So there are a lot of slides here, which I'll be, of course, sharing at the end of my talk to all the participants. So these are the first generation antipsychotics, and they are themselves of three broad categories: the high potency ones like haloperidol, haldol, fluphenazine, prolixin, and then the mid potency perfenazine, and then loxapine, and then low potency chlorpromazine. So as you see, the high potency ones are used in smaller doses, low potency ones are used in higher doses. The second generation antipsychotic drugs, as you see here, there are several of those, and some of them will be spending a bit more time today. Clozapine, olanzapine, risperidone, paliperidone, quetiapine, asenapine, haloperidone, ziprasidone, and lurasidone. One thing that is common to all of these is that, number one, the first generation antipsychotics work primarily by blocking dopamine. The second generation antipsychotics, which are here, block both dopamine and serotonin. So they have some benefits and some side effects, as you would see there. We can get into more details later. And then there is another class of antipsychotic drugs, which is, you might call them the third generation. These drugs do something interesting. They partially block or partially stimulate the dopamine receptors, and there are three of those: aripiprazole or Abilify, brexpiprazole or Exulti, and cariprazine or Vraylar. So these are the three. So there are three generations of antipsychotics, and there are many medicines available across each of these categories. So the big question is, how do we choose among these in a person for whom you're starting the medicine for the first time? So the answer for this is not simple. The answer is there is no one particular medicine that is perfect for everyone. It's a choice that has to be made between what is likely to be effective in a given person and what is likely to cause the least amount of side effects for that particular individual. So it has got to be an individualized decision. For example, someone who is an active college student who needs to be awake during the daytime and alert, and you would want to choose one of the less sedating of the medications for someone like that, something like aripiprazole or maybe risperidone, and not something like quetiapine or olanzapine. On the other hand, some of these side effects may actually be advantageous. If someone who is particularly agitated and anxious and needs to sleep, catch up with lost sleep, something like olanzapine or quetiapine might actually be somewhat better. So the choice has to be made by what is the kind of medicine that is most likely to be tolerated by a given person. And of course, there is also the issues of efficacy. And by and large, at this time, the state of knowledge is that all antipsychotics are about similar in their efficacy, with the exception of the top medicine in this list that you see here, clozapine. We'll get more into detail about that a bit later. So coming back to our question, what is the first line to treat an antipsychotic in a 16-year-old first episode patient? The answer is, I would say, an individualized decision based on your experience, based on what the patient's preference is as to what are the side effects that particular person does not want. And so based on that, one would have to go with a decision. The general principle, though, in a first episode patient it's always better to start with a lower dose and build up the dose so that you minimize the likelihood of side effects. And also, an important point to remember is that first episode patients tend to require lower doses of the medicine than patients with multi-episode chronic illness. So it's always a good idea to start with a smaller dose of the medicine. For example, if you're starting risperidone, starting with maybe 1 milligram a day might be a reasonable starting point, and build up to the point where you're beginning to see benefits without any significant side effects. So that's the general approach to treatment of a first episode psychosis patient. The other part of this question is, what do you still treat a person if the hallucinations are not there anymore? The answer is absolutely, because the goal of treatment with antipsychotic drugs is not only to treat the symptoms, but also to prevent relapse. So in a first episode psychosis patient, if, for example, the person is not taking medications because the symptoms got better and no more need for medicine, and the patient stops the medicine, the risk of relapse is in this slide that I'm going to show, slide number 17. The relapse is quite frequent. It is about 70% in the first psychotic episode. Within the first 5 years, almost 70 to 80% of patients would have relapsed. The cumulative relapse rate is about 82%, who would have experienced at least one relapse over 5 years. So it is it's an important point to explain to the family members and the patients that the goal of treatment is not only to improve the psychosis, but also to prevent a relapse. So, any questions at this point? Feel free to either speak up or type up your questions in that text box that you should have available. Or if you have a question that you want to bring up later, that is fine, and we can go to the next question. Okay, so let's move on to the next question on my list here. While we are in the topic of the antipsychotic drugs, I have a question here about the use of first generation antipsychotic medications in those with high levels of weight gain. This is a very good question. As I said earlier, and let me get to the side effects slide here, which is slide 22. Antipsychotic medications have a variety of side effects. There are the problems of sedation, sleepiness, and extrapyramidal symptoms, which include like Parkinsonian-like features and tremors, restlessness, and also weight gain, which is a significant problem in a good number of them. And since this question is about weight gain, so let's talk about that for a moment. In general, second generation antipsychotic drugs tend to have more frequent side effects of weight gain, but not all second generation antipsychotic drugs are like that. Some are more than the others. On the other hand, first generation antipsychotic drugs, which is in this slide at the back here, these medications, haloperidol, perfenazine, fluphenazine, clopramazine, these are the first generation antipsychotic drugs. Even they are not the same in terms of side effect of weight gain. The high potency drugs like haloperidol and the mid potency like perfenazine are better in terms of side effects of weight gain. So someone who has a particular risk of gaining weight or already has the problem of overweight, you would want to choose either a first generation medicine that is high potency like haloperidol, or a second generation antipsychotic drug, such as in this slide, that is also less likely to cause weight gain. And so the medicines that come to mind in terms of low risk of weight gain among the second generations are at the bottom here. The minimal weight gain with ziprasidone, lurasidone, these are among the ones that are a little better. So first generation drugs could be used to prevent weight gain, but they have the problems of extrapyramidal side effects like akathisias, restlessness, the problem of shakiness, tremors, or rigidity, and so forth. So on balance, if one could choose a second generation medicine like ziprasidone or lurasidone, which does not have either the problem of weight gain or the problem of extrapyramidal side effects, that might be better. But in some situations, we may have to use first generation medicine. So any questions here at this point? Great. So we could get to the next question with regard to the antipsychotic drugs that I have on my list. And then, if time permits, we could go to other medicines like lithium and other mood stabilizers and so forth. So the question here is, are there any anticholinergic risks for children with the use of antipsychotic medications? This is a very good question. By anticholinergic effects, we mean effects that result from blockade of the cholinergic receptors, which have the effect of producing some symptoms like dry mouth and blurred vision, constipation, and so forth. There are some medicines that we routinely use in the treatment of psychotic disorders called anticholinergic drugs, which are also called anti-Parkinsonian drugs, to prevent extrapyramidal side effects. So these are the ones that are most likely to cause anticholinergic effects. Examples of this is benztropine, for example, Cogentin. But they are not the only ones that produce anticholinergic side effects. The important point to remember is that anticholinergic effects could be a part of the antipsychotic drugs themselves. For example, some first-generation antipsychotic drugs, like perfenazine or chlorpromazine, they have their own anticholinergic side effects as well. Now the question is, what about children? Do they have the same level of risk of having anticholinergic side effects? That was part of this question, and the answer is absolutely. There is no reason why children are any more immune from having these side effects of anticholinergic nature compared to adults or older adults, even though older adults may be even more likely to have anticholinergic side effects, especially those who are middle-aged or older. So we have to be particularly careful. So it's better to use medicines in such individuals, use medicines that are less likely to cause anticholinergic side effects, such as risperidone, for example, has relatively less, and paliperidone, and so forth. Clozapine has high level of anticholinergic side effects. Any questions up to this point? I see some questions being typed up here. I can read them as we go along. can we get copies of slides? Absolutely. We will get these slides to you. And also, Rachel and Vanessa will be sharing the recording link and the slides with all the registrants after the event. So one question here is monotherapy ideal treatment for someone with a psychotic disorder? Absolutely. By and large, there is no evidence that using two antipsychotic drugs at the same time is a good idea. It may become necessary in some individuals when one medicine has failed, and even then it is a better idea to try a different monotherapy as opposed to combining two antipsychotics. And if you do combine two antipsychotics, it's better to combine two antipsychotics that have different kinds of effects. For example, if you combine someone who is on a second-generation antipsychotic drug, such as, let's say, risperidone, with another second-generation antipsychotic drug like olanzapine, that's not a good idea. But on the other hand, if you have someone who is on a second-generation drug like, let's say, clozapine, and there are not enough benefits, you could try a third generation, maybe a partial agonist like aripiprazole or brexpiprazole or cariprazine, one of those. So use combinations only if needed, and preferably of different classes of medications. So that's an answer to that question. So that was Derek. Derek, does that make sense to you? So Kathy Adams asks another question. Recent referral of a young woman with a first episode. During 3 weeks of hospital stay, it was determined that she was refractory or had a high side effect burden with two antipsychotic medications, so she was placed on Clozapine. I was wondering what options will be in the future if Clozapine is no longer producing benefit. It's an excellent question. I was also going to get to that because there was a question that had come up here, even before this meeting about this. So Clozapine works when, first and second generation drugs don't work in about 30 to 50% of the time. There are a significant number of people who are treatment resistant that do not respond to even Clozapine. So we kind of get to a point there as to have to scratch our heads as to what the next steps are. There are a couple of options. As I said earlier, one option is to judiciously you try a second antipsychotic drug of a different class in a Clozapine non-responsive individual, and choosing a drug that is a different pharmacological profile, such as a partial agonist, might be one way to go. And sometimes I've found benefits in combining Clozapine with a first-generation drug, a mid-potency one like perfenazine or trilofone. So those are some of the options. The other option, which is often used but with very little evidence for its clear-cut benefit, is using a mood stabilizer like valproate or lithium. The third option, which is somewhat more likely to be effective, but of course would require a patient's buy-in and the family members' buy-in, is to combine ECT with Clozapine. So those are some of the options. And then there are more experimental options with newer treatments like transcranial magnetic stimulation and so forth. But I won't go into a lot of those details because the evidence is just still very, very weak. So Kathy Adams, does that answer address your question? Feel free to type in your response as we go along. So Andrew McAlliso asks the question, Does the risk of anticholinergic side effects increase with the addition of mood stabilizers? The answer is yes. Some of the mood stabilizers like lithium also have their own inbuilt antipsychotic effect. So one has to be cautious in using combined use of mood stabilizers in those who are already on an anticholinergic kind of antipsychotic drug or on an anti-Parkinsonian drug. So Derek asks second question, is Adderall ever an advisable treatment for someone with comorbid psychotic disorder and a history of paranoia? My answer would be yes, it is not a good idea because, Adderall, among other stimulants, is likely to compound the problem of psychosis because it stimulates the dopaminergic system and is likely to trigger a psychosis. So in general, someone who currently has any comorbid psychotic disorder and currently has paranoid symptoms, I would definitely avoid Adderall at that point. So I'm not seeing any other new questions, so I can go back to the list of questions that I have here while we wait for other new questions. So one question I have here is, does high or low blood sugar have an impact on the efficacy of antipsychotic drugs in children? So the answer to that is, high or low blood sugar to begin with is not necessarily likely to impact on the efficacy of any antipsychotic drug. For example, if a person has borderline diabetes but has psychosis and needs an antipsychotic drug, the efficacy of that antipsychotic is not likely to be in any way impacted by the blood sugar levels. But on the other hand, the choice of what antipsychotic drug you would use will have to be guided by the baseline status of blood sugar. If someone is on the verge of being diabetic, you would not want to use an antipsychotic drug that is likely to increase that problem, such as olanzapine, very likely to do that, Clozapine, and to some extent risperidone. All of those can increase the likelihood of blood sugar elevations, glucose intolerance, and weight gain kind of problems. So Kathy Adams asked the question, what about stimulant medication in a stable patient with complaint of cognitive slowing, attention, focus, concentration, and recall? Now my answer to this is that stimulants like Adderall are often used in practice for people with negative symptoms and cognitive slowing in practice, but this is not exactly an FDA-approved indication. So, of course, clinicians use these non-approved use of different medications based on their clinical judgment off and on, and sometimes they say that using a stimulant like Adderall might actually make a person with otherwise stabilized psychosis but with more prominent cognitive impairments to get benefit from those. And I've seen a lot of that in practice. I would not necessarily recommend that because cognitive slowing is better addressed by training the brain with cognitive remediation, lumosity exercises, or looking at the medications and taking away any anticholinergic drugs because they're very bad for cognition. So many times cognitive slowing gets better if you simply cut down the dose of cogentin or keep the dose of the medications to the minimum required and to reduce polypharmacy. There is always a risk with the stimulant medication of triggering or worsening psychosis. But if one is absolutely convinced that psychosis is long gone and there is no evidence of any recurrent psychotic symptoms and nothing else has worked, of course one could take some risk and use alternative treatments like stimulant medications. even there I would first try more alerting medications that are more commonly used, such as Wellbutrin, that is bupropion, or another stimulating antidepressant, rather than going to stimulant medications, especially if the diagnosis is clearly one of a primary psychotic disorder like schizophrenia. So let's go to some other questions, and there have been a number of questions on Clozapine. What are the effects of early use of Clozapine? It's a very, very good question, and a lot of thinking has been going on in this area and in the literature. Standard teaching is that Clozapine is used when 2 antipsychotic drugs have failed. When you say failed, 2 antipsychotic drugs of different classes have been tried in adequate doses, FDA prescribed adequate doses like on the slide that you see here, for at least about 2 months each. And then if they fail, you go to Clozapine. So by and large, people, in the early course of psychosis in the first 1 or 2 years, Clozapine is not used early on. But there are some people some clinicians and investigators, they argue that Clozapine may be worth bringing in as an option even in the early course of illness during the first couple of years and so forth. I have looked at this literature at some length, and I'll send some articles to all of you. There is one recent systematic review on this, which suggested that there were 4 studies using Clozapine as the first antipsychotic drug, by comparison to another antipsychotic like risperidone. 2 of them showed Clozapine being superior and 2 of them did not. So remember that any decision that one makes in terms of antipsychotic drugs, you have to consider side effects as well as benefits. So we don't have clear-cut evidence that Clozapine is necessarily superior in the early course of the illness, even though there may be some benefit in some studies. But secondly, we also know that Clozapine has substantively more side effects than other antipsychotic drugs. So with that in mind, one has to be cautious in choosing Clozapine as the first choice. And there's a third reason why I wouldn't go to Clozapine as the first choice, and that is that the majority of people with the first psychotic episode respond to antipsychotic drugs of whatever kind you give. Why not give them something that has less side effects as the first choice? Over 80% of people with first psychotic episode respond to antipsychotic drugs. Treatment resistance generally begins later. So all of those reasons, even though there are some studies suggesting that first choice of Clozapine may be a good idea, I would be cautious about that approach at this point. But at the same time, if a patient who is still within the first couple of years of the illness but has already failed 2 antipsychotic drugs, I would definitely go to Clozapine. So Andrew McCalliso asked the question, is neuropsychological testing helpful to patients with psychosis who are having cognitive issues? My answer would be yes. First of all, cognitive impairment is very common in psychotic disorders. Probably over 90% of people with schizophrenia or other serious psychotic disorder like psychotic bipolar disorder have cognitive impairments. Sometimes they report them and sometimes they don't. If they don't report them, there is no other way to know that without doing a cognitive battery. And there is another good reason to do a neuropsychological testing, and that is as a way to monitor progress and course of illness. There are many individuals who are fortunate to begin looking better with treatment, in them the cognition actually begins to get better, and it'd be good to know if it is getting better. It'll also be good to know if it is not getting better, so that we could choose who are the people that would require a more systematic cognitive rehabilitation strategy. Cognitive remediation, also called cognitive enhancement therapies, are actually quite effective. Studies show that they do benefit in improving cognition at least about a half of a standard deviation, which is quite significant and can actually make a big impact on quality of life. So while I hope that answers the question, while we're waiting for the next question, let's take one other Clozapine related question. So the question here is, our early psychosis treatment program received a copy of the book promoting Clozapine as a first-line treatment for psychosis. NAMI was a supporter of this publication. Do you have any thoughts on this? I guess this question I already addressed. There was another question about the same one. So I would say the literature is still somewhat divided on Clozapine as a first line of treatment for psychosis. I would probably need more data before confidently recommending that as a go-to option. Moving on to other questions about antipsychotic drugs. There is the very interesting question here about marijuana. The question is, in the case of marijuana-induced psychosis, what would you recommend for treatment? Eliminating substances was my first thought, but would you treat with medication if only occurring during substance use? This is an excellent question and often a clinical dilemma that we face as clinicians. So there are two ways to think about this. There are many people who come to us, increasingly so in recent times because of the liberalization of marijuana, psychosis that seems to be triggered by marijuana. And it turns out that some of them get completely better when they stop using marijuana, and they don't go back to psychosis unless they start using marijuana again. You might call them marijuana-induced psychosis and not necessarily schizophrenia or other psychotic disorder. So that's scenario number one. Scenario number two is there are people who come to us with psychosis in the context of marijuana use, and then they stop the marijuana, but the psychosis doesn't go away for weeks or months. These are people who we believe have a primary psychotic disorder like schizophrenia that are triggered by cannabis but not necessarily caused by cannabis. How do we know how to distinguish between these two possibilities? If a person has a psychotic disorder that always came after either starting to use cannabis or after increasing the severity of use of cannabis, and was never seen in the absence of cannabis, that will be the first kind of patients, cannabis-induced psychosis. And then there are those people who are beginning to have prodromal symptoms of psychosis already, and then continue to use cannabis, and then they develop psychosis, and even after the cannabis is discontinued, they have psychosis. Such people have, in my view, a primary psychotic disorder like schizophrenia. So a good clinical history and the temporal relationship between cannabis use and psychosis, clarifying that would be very, very important. Now, if you have decided that a given patient has a very clear-cut cannabis psychosis, induced by cannabis, never outside of cannabis, and completely gets better without cannabis, obviously the main treatment is to address the substance abuse problem and to work with the individual along with substance abuse counselors to get off of the drug and stay off of the drug while closely monitoring. In such situations, do we use cannabis? Do we use antipsychotic drugs or not? Now that depends. I've had a patient in whom, it was very clearly cannabis-induced psychosis, and the patient was very, stable and had insight about the psychosis, was willing to work with me, even see me on a everyday basis for a few days. So I simply worked with her to get her off of the cannabis without an antipsychotic drug, and every day that went without cannabis, the psychosis settled down. And it only came back 3 months later when she used cannabis again. But I would say that kind of a patient is rare. Most of them are more acutely ill, have a loss of insight, may be agitated, sometimes putting themselves at risk or others. In such situations, one has to use an antipsychotic drug, at least for a temporary period of time, until the psychosis settles down. And when the psychosis settles down, I would continue the antipsychotic until we are sure that the person is safely off of the cannabis, and after a period of a good few months, attempt to very slowly cut down the dose of the antipsychotic drug to a minimum, and then after a year or two, take it away, give it a try, and see if the psychosis comes back or not. So that would be my answer to that question, which is clinically quite challenging. So there's a question from Derek. Working with an individual who was a star football player in high school and per family has a significant history of undiagnosed or treated concussions. Individual also had onset of bipolar and psychosis in the teenage years. Does the presence of brain-related injury affect treatment options? This is again an excellent question. We do see many people with psychotic disorders who have concomitant traumatic brain injury problems. An important clinical distinction to be made, just like with the cannabis question that we just addressed, as to whether the TBI, the traumatic brain injury, is causally related to psychosis or is it simply coincidental. If we have a patient who had a significant head injury and psychosis came only after that, one could consider, and in the absence of a family history of psychosis, you would wonder whether there is a traumatic psychosis, a psychosis related to trauma. But consider that the treatment of psychotic disorders is etiologically agnostic. So when we use antipsychotic drugs, it is to treat the syndrome, it is to treat the psychosis. We're not treating the underlying cause. If there is ongoing psychosis due to head injury, you would still use an antipsychotic drug as long as the psychosis is still a problem. Just like, there are patients, for example, who have epilepsy, who also have psychosis. And you would use an antipsychotic drug along with an anticonvulsant drug, even if the cause is well known to be the epilepsy problem. So treatment-wise, I would not see any distinctions. Psychosis, as we see, is a final common end result of many different conditions, and sometimes it is an underlying genetic cause. Often schizophrenia is one of those which has got a strong genetic basis. There are some others in whom the underlying cause might be, head injury or birth complications. In some others, it could be an underlying predisposition that has been triggered by drugs of abuse. So psychosis is a final common end result of many different causes, and the treatment would still be with antipsychotic drugs and appropriate psychotherapy. So one has to address the cause whenever possible, but also treat the syndrome that the patient presents to us with. Thank you for that question. So while we are waiting for the next question, we still have about another 15 minutes. I have a couple of other questions here that we could get to. So the one question I have here is, what are the reasonable indicators for suspicion of autoimmune encephalopathies, appropriate initial assessment, and partnership with neurology? This is an excellent question. So in recent years, there has been an increasing recognition that a small number of people, maybe about 1 to 2%, those who present with psychotic symptoms may have an underlying autoimmune condition, a particular condition called NMDA receptor encephalitis or NMDA receptor encephalopathy. They look like psychosis, but then they have an underlying cause, which is anti-brain antibodies that are targeting some key aspects of their brain function. So the question is, how do we know who might be at a particularly higher risk for this kind of a NMDA receptor encephalopathy? So the clinical indicators are that people who present to you with a psychotic episode for the first time, who do not have any other risk factors for psychosis, but also have prominent autonomic problems, like rapid heart rate, or blood pressure fluctuations, or fever, or unusual involuntary movements, seizure-like symptoms. So those are the giveaways for raising the suspicion of an NMDA receptor encephalopathy in such individuals. There are diagnostic tests for this. You can do a blood test and identify, or even do a lumbar puncture, cerebrospinal fluid, and look at the titers of anti-NMDA antibodies, which are particularly elevated in such individuals. And treatment can be quite specific. So NMDA receptor encephalopathy patients do not respond well to just antipsychotic drugs. They may need immunotherapies. Sometimes it might involve immunoglobulin antibodies as a treatment, or anti-inflammatory drugs. Steroids can sometimes be helpful, and sometimes one may have to replace the plasma by new plasma, which is called plasmapheresis. So it's fortunately not a common condition, and the kind of patients that present with an NMDA encephalopathy are often seen in medical settings, because one of the risk factors for this syndrome is actually the presence of a cancerous illness, especially ovarian cancers. If you have a woman with an ovarian teratoma history presents with a psychotic episode, you would want to consider an NMDA receptor encephalopathy. So any questions about that? It's not a common condition. There was a recent book written on this by a woman who went through an NMDA encephalopathy. It's called Brain on Fire. If you haven't read that, it might be worth reading that. As we go forward, we are going to discover more and more of these kinds of what you call secondary psychotic syndromes. Psychosis, as I said, is a final common end result of multiple causal mechanisms. In some people it is autoimmune, in some people it is genetic, in some people it's head injury, in some people it's drugs, and so forth. So keep that in mind, that psychosis is like anemia or chest pain or headaches. So it's like when you say someone has psychosis, it's a broad category of symptoms for which there are many causes. So we are coming closer to the last 10 minutes. Let me see if I have any questions that are here on the list that we have not addressed yet. Okay, so here's the question about the role of lithium augmentation in those who are not overtly bipolar, those with suicidality, agitation, mood instability, and so forth. So the first point I want to say is that lithium is indicated by the FDA for bipolar disorder. So one could use lithium, as clinicians do, in other indications as well, but then it would have to be based on clinical experience, and some literature exists on this. So there are patients with recurrent depression who are not overtly bipolar, or those with bipolar 2. Those are people with bipolar disorder who haven't had a frank manic episode but only hypomanic symptoms. They might benefit from lithium as well. Now there is some good literature which suggests that lithium has a protective effect against suicide. Even though I can't say that it is highly well established, there are more papers supporting that than not that I have seen. So lithium is definitely a good idea in people who have recurrent suicidal thoughts, whether it's related to bipolar disorder or recurrent depression or bipolar 2 condition and so forth. Also, it's important to keep in mind that lithium is not entirely a safe medicine. Its safety margin is relatively narrow. It has to be used with caution, with close plasma level monitoring. There are side effects, including kidney and thyroid side effects, weight gain, some anticholinergic side effects. So all of those have to be kept in mind as well. So that was the question on lithium. So there are many other questions, I'm sure, about treating bipolar disorder and depression, which did not come into today's discussion. But next time we meet, I will try and have a bipolar expert with me who can address bipolar disorder or major depression-related questions, and we could make it a good dialogue with more than one person with experience. There's one last question here that we can get to, since I don't see any other new questions coming up here on the list. And this is about management of catatonia. How do you manage a patient with a catatonic syndrome? So this is a question that would probably need a lot more time to go into details, but for those of you who are not familiar with this, catatonia is a group of symptoms, mostly motor symptoms, that present with either catatonic stupor, mutism, posturing, or stereotypic behaviors, sometimes motor excitement, and so forth, that some people with schizophrenia have. Even some people with bipolar disorder and some people with depression can have catatonic symptoms. So catatonia is not a separate disorder. It is a syndrome that can cut across multiple diagnoses. So when you do see a patient with catatonia, which is not common but still we often see in hospital settings, the question becomes, how do we get the person out of catatonia so that we can then figure out what is the underlying cause for the catatonia and we can treat the underlying cause. Sometimes the catatonia could be due to an underlying organic brain disorder. There is a condition called malignant catatonia which may be caused by antipsychotic drugs. So the differential diagnosis is very important. Not all catatonia is one thing. But then there is a patient, let's say, who presents to you with a catatonic stupor, who's just lying in bed or sitting up and not doing anything and not talking. He's stuporous and mute. What do you do? One thing that works very well and very quickly is a benzodiazepine. like the lorazepam, 1 or 2 milligrams intramuscularly, or repeated 2 or 3 times a day, quickly brings out people out of catatonia, so that you can begin talking to the patient and making sense of what the underlying diagnosis is. There are some patients in whom one needs to use a longer-term benzodiazepine like lorazepam or diazepam in a continuous basis, and fortunately those are not common. In the majority of individuals, you'll be able to figure out the underlying disorder, whether it is depression or a schizophrenic catatonia or an organic brain disorder, and then the treatment will have to be appropriate based on the underlying cause. So that was my last question on my list, and we have about 3 minutes left. Let's see if we have any other questions for the participants. I see that Derek is typing, so I'm sure there's going to be a great question. Thank you, Derek. You're totally very welcome. This has been a great learning experience for us as well to do this. And as you saw here, having a list of questions ahead of time actually helps for us to use the 1 hour very productively. So we will let you all know about the next date, and would love to have as many questions ahead of time as possible, so that we will have a great session beginning next time again, and we'll have other experts join me as well. And just to conclude, I want to say that we will have all of these slides sent out to you in the next couple of days. I will also send you a summary of the answers to each of these key questions that came up. And I might add 1 or 2 relevant articles to go with that as well, so that we can build a ongoing collection of useful articles as we go forward. So I think that is the end of our session. Rachel and Vanessa, do you have anything by way of concluding remarks?
Yeah, so thank you, Kesh, for
today's session, and I will forward the slides and the recording to everyone as well.
Okay. Thank you all very much, and have a wonderful day. Bye-bye.
Thank you, everyone, and you should get a Gipper link for a survey at the end of our meeting. Thank you.